Thank you, Devashish. It's really an honor and a privilege for me to be giving this oration today. It's interesting because the first oration I ever did, I think, was about 8 years ago, again in Nagpur. It was a Dr. Tayade Memorial Oration way back then, and it's really a privilege to be back here today. Today I'm going to talk about damage control orthopedics, and I need to acknowledge Dr. Rajashekharan, who has a great contribution in this, as well as some of the slides which I've taken from AO Trauma Archives. Now, I'll start with a clinical example, one which is from the AO Trauma Archives, but one which all of us would have faced at some time during our career. And this is a young person who gets involved in a road traffic accident, has just a femoral shaft fracture, is otherwise stable, looks okay. You take him to OR the next day and he operate on his femur, you nail it, and the day after suddenly he has problems with his breathing, deteriorates, has to be intubated and transferred to the ICU. And we wonder why this happens. And we give various reasons for it. Maybe he had some occult chest injury. Maybe this is fat embolism from the marrow that has gone stuck in his chest. We blame the timing of surgery, or he should not operate on the second or third day after a femur fracture. But we really need to look at what the real cause. Is it all this, or is it that this patient has not been adequately resuscitated before surgery? So we really need to know that India has become the road traffic accident capital of the world, and one person dies on the road almost every 3 minutes. And that means that since I left Patna yesterday morning, more than 500 people would have died on the roads in India. For every one that dies, there are 10 who are severely injured and another 50 who have less severe injuries. So there's a huge load of trauma patients that we have to deal with. On top of that, this is the leading cause of death in India between the ages of 15 and 40. And these are people in the prime of their life, often the single earning member of the family. And so you can imagine the cause, the problems that this causes, and the entire family suffers as a result of this. So we in India really have a responsibility to get our trauma management act together. And this is not easy. It's not one person's job. It really needs a team approach. It needs multiple departments as well as specialties in the hospital to be involved. I think coordination between different teams is important. You need to communicate not just between teams, but with the patients, relatives, etc. And things have a potential of going wrong at various stages. So the patient who may be alive on arrival, but what happens in the next few minutes or the next day or after 2 or 3 days or maybe even after 2 or 3 weeks really can totally alter what is going to happen to this patient. So you can have different clinical scenarios, and these are patients we've had to deal with quite recently. This patient came with his entire bowel hanging out with a circumferential wound extending right across to his spine. His one leg was amputated. He was stuck between the train and the usual sort of story that we see. His BP was barely recordable. His lactates were 11. Gases were off. He was aggressively resuscitated, had to be taken to the OR because part of his gut was necrotic, which was removed. He survived the surgery but died about 4 or 5 hours later in the ICU. Another scenario where a patient with, again, pelvic and a femur fracture with massive bleeding. His hemoglobin was 2, his lactate was 16 on arrival. His BP could hardly be recorded. He was initially resuscitated, but by the 6th day, that was what his lungs looked like, or chest x-ray looked like, and then finally he died on the 10th day. Or you have a situation where patient presents late with septicemia, with multi-organ failure, and dies about 3 weeks after his injury. But even though the death has happened over different time intervals, the seeds were sown on the first day itself. As Abraham Cowley had said, there's a golden hour between life and death. If you're critically injured, you have less than 60 minutes to survive. You might not die right then, it may be 3 days or 2 weeks later, but something has happened in your body in that 1 hour that is irreparable. And that culprit is shock. Shock is like a tsunami or a hurricane, and these are images from the recent tsunami in Indonesia or the sort of Hurricane Florence in Florida, and the devastating secondary effects last a long time after the initial event. This affects almost every organ system in the body, which can also lead to further problems, which then goes into a vicious cycle. We have to understand the concept of what is today known as occult shock. That means inadequate resuscitation may be obvious clinically or may be occult, what we call the occult hypoperfusion syndrome. So while we are all very aware of the golden clinical of signs of shock such as hypotension, tachycardia, and a reduced urinary output, sort of being pathognomic of shock, these signs are not really reliable after the golden hour, because the patient can be continuing to bleed after his BP, etc. have been stabilized. In a hypertensive patient, even a blood pressure of 90 may be a severe hypotension, and young patients, their normal pulses may be 60. So in 90 may not be normal for that particular individual. So if the clinical signs are restored to a normal blood pressure, normal rate and urine output, you can say that the patient is stable, but you can't say that he has been fully resuscitated until his arterial blood lactates are normal, he's not acidotic, and his base deficit comes within normal limits. And then you can say that this patient is resuscitated. If these are not sort of adequately corrected, he is suffering from what we call occult hypoperfusion, and you need to take action to prevent the problems that result from it, which is the silent sliding pathway. You get hypoperfusion, you get reduced oxygen delivery. This leads to oxygen debt, which then leads to anaerobic glycolysis, which causes increased lactates and acidosis, cell death, and multi-system organ failure. And if in this situation you add the trauma of surgery, it can amplify the problems that are caused. So occult hypoperfusion is associated with increased mortality even in hemodynamically stable patient. And if you look at survivors and non-survivors and then compare their blood lactate levels, you can say there's a distinct difference. So occult hypoperfusion leads to tissue hypoxia, which then leads to both anaerobic metabolism and tissue acidosis. And anaerobic metabolism shows up as serum lactate levels, and the tissue acidosis shows up as an increased base deficit. And the depth and duration of shock leads to a cumulative oxygen debt. So you can only say the patient is completely resuscitated when the oxygen debt has been repaid, tissue acidosis is eliminated, and aerobic metabolism is restored. And how do you know that if the clinical signs do not show it? Well, interleukin-6 and HLA-DR class 2 molecules are able to accurately predict the clinical course after trauma. But these are not easily available and not practical in the acute situation. Nor are the injury scoring systems going to help you to assist in the decision making in the acute resuscitation phase. Luckily, we have serum lactate, which is a surrogate marker and which has been shown to be a reasonable indirect measure of tissue perfusion or occult hypoperfusion. And this study, has been proposed by O'Toole et al. In Journal of Trauma 2009, where they say they've discussed the traffic light system, where if the lactates are over 2.5 millimoles, you should not be doing definitive surgery. If it's between 2 and 2.5, you look at what's happening to it and then decide whether the patient is ready for surgery. And if it is less than 2, then this patient would be suitable for what we call early total care. If you also look at the incidence of occult hypoperfusion in the trauma patients, in major trauma patients, if you look at patients who are clinically obviously hypotensive, in the initial admission, it will be not a huge number. But if you look at the lactic acid levels and then use that as a measurement of a patient suffering from occult hypoperfusion, you'll see that the percentage of this is much higher. One has also looked at the lactate levels versus mortality, and if the serum lactate levels are elevated for less than 24 hours, the mortality rates are low. If it is for more than 24 hours, it goes as high as 25%, and if they remain elevated for more than 48 hours, then the mortality rates are as high as 86% in these polytrauma patients. So the concept of the silver day was brought about by Blow and Magliori. They talked about golden hour and the silver day, the detection and correction of occult hypoperfusion within 24 hours improves the outcomes of major trauma. So they initially did a pilot study of 31 patients with an ISS score of more than 20 who were hemodynamically stable, and they had 4 deaths, 6 multi-system organ failures, and 13 respiratory complications. And all these patients had a high lactate levels in the blood. They followed it up with aggressive resuscitation of patients who, in the next sort of 58 patients, 44 patients with the resuscitation had their lactates back within the 24 hours period to normal. And in this group, they had no deaths, 3 multi-system organ failures, and 10 respiratory complications, while the 14 who had persistently raised lactate levels had 44% death, 36% respiratory complications, and 50% multi-system organ failures. So again, showing that the lactate levels, if you resuscitated these patients, this greatly improved the outcomes of the patients. Now we talked about multiply injured patients, polytrauma patients. But what about the solitary femur fracture, the case that I showed you first? Well, the results even in this are directly correlated to the presence or absence of occult hypoperfusion and not on the timing of the long bone fixation. Okay, so Crowell and Young did this study when they looked at occult hypoperfusion associated with increased morbidity in patients undergoing femoral fracture nailing. Okay, so in the group that had complete resuscitation, that means the lactates were normal before fracture fixation, there were 27, and 20 still had a raised lactate levels at the time of surgery. And if you compared the complication rates and the costs in both these groups, the difference is really stark. Okay, so it's a huge difference when you operate on these patients when they're adequately resuscitated, or you operate on them when they are inadequately resuscitated. And this is a simple thing all of us can take to our practices, is to make sure that patients are adequately resuscitated before we take them on to surgery. You also have the opposite disaster, and that is overzealous fluid resuscitation. Remember, even 750 milliliters of crystalloids can activate cytokines, and if you give them too much of IV fluids, you can lead to an iatrogenic dilutional coagulopathy, which then leads to further problems along the way. So the cyclic hyperresuscitation cycle, you have a patient in hypotension, you give him fluids, his BP comes up, and then whatever bleeding that had stopped, the clots that had formed because of the hypotension, then pop, and then they start bleeding again, and they then further go down to hypotension, and this cycle gets repeated again and again, resulting in a more sick patient in the ICU. And you need to realize that in these early phases of resuscitation, you don't need to get the BP right up to 120, so that you keep what we call a level of permissive hypotension during your resuscitation in the initial phase of management. Remember, a stable patient is different from a totally resuscitated patient. Just because the patient is stable does not mean he's totally resuscitated, and this difference could be the difference between life and death. Okay, so now we come to what has been happening with trauma care in terms of the history, and if we look back to before the 80s, none of these severely injured patients got operated on early. They remained in the wards, they were on traction. Patients were thought they were too sick to be operated on, and obviously the outcomes were poor. And then in the 80s, people started aggressively resuscitating the patients and fixing all the fractures. So various groups in Europe and in the US started doing this and showed much better outcomes with early operative stabilization of these multiple fractures. Okay, so we entered this history of trauma care, so-called enlightened era, when operative treatment became the rule. You also had to combine this with aggressive resuscitation, and we gradually came to think that patients were too sick not to operate on. So however sick they were, the idea was to get all their fractures fixed as soon as possible so that you could mobilize these patients. And this worked well for some time, till people started seeing problems in some of the severely injured patients. So while in patients who did not have a significant chest injury, this was shown by Pape, there was a significant improvement with early total care. There was a subgroup of patients who also had a severe chest injury where early IM nailing led to a higher incidence of post-traumatic ARDS as well as a higher mortality rate. So this concept of the second hit came about, and one started looking at this a little more carefully, because early total care was based on the hypothesis that stabilization of the soft tissue and bones decreased the inflammatory load and also helped patients move about and get into the upright position. But surgery was also a second hit, because you had increased blood loss, you could further drop the blood pressure, the fluid requirement increased. Patients were often hypothermic during surgery because we tended to keep the OT temperature levels very low. Okay, so the two-hit model was proposed by Moore and Moore from Denver. So they said that after injury, patient's inflammatory system is primed and vulnerable to a secondary insult, and if during this period of priming of the inflammatory system, a second insult was provided, it resulted in an amplified systemic inflammatory response syndrome, which then would lead to major problems including multi-system organ failure. So the first insult led to a moderate systemic inflammatory response and moderate immunosuppression. And then during this period, if they had a definitive or sort of prolonged surgery with increased blood loss, you could sort of aggravate the position, leading to a severe systemic inflammatory response and a severe immunosuppression. The severe systemic inflammatory response could lead to multi-organ failure. The severe immunosuppression could lead to infection, which could then lead to multi-organ failure. So the concept of orthopedic damage control came to be born. The purpose was to avoid worsening the patient's condition by a major operative procedure before he was over the systemic inflammatory response. And this term was originally coined by the US Navy in reference to keeping afloat a badly damaged ship by procedures to limit flooding, stabilize the vessel, isolate fires and explosions, and avoid their spreading. So this damage control term came into orthopedics from the US Navy, who used this to limit the damage or continue working with a damaged ship. So then this debate started between early total care versus damage control surgery, and the consensus from the literature, there's only one randomized control study which comes slightly in favor of damage control orthopedics, but the general consensus is that in these very severely injured patients, it's probably better to do damage control orthopedics rather than early fixation. You did still need to stabilize the fracture, but you do it with an external fixator which was modular, so that you spent less time, you didn't cause blood loss, and that would hopefully improve the condition of the patient. So the surgical strategy was to divide patients into groups. If they were stable and resuscitated, then surgery was safe. You could go on with your definitive surgery. If they were stable but still acidotic or their lactate levels were high, they really needed further resuscitation, and you'd look at that and decide what to do. While if they failed to stabilize, then you were only permitted to do damage control surgery. So a few examples: this patient with multiple fractures, sort of a open book pelvis, femur, tibia, sort of initial, he came with a lactate level which was around 5, came in shock, was resuscitated. Then he was taken to OR, he had his external fixators put on, and then once he had stabilized, then we went on to fix all his femur, tibia, and then a couple of days later we went ahead and fixed his pelvic fractures, and then he was able to get mobilized after that. Another example, a young girl involved in a train accident and the severe kind of injury. So you have to get your priorities right. You need to reduce the hip, you need to stabilize the femur, and an X-fix for the, so here we reduce the hip, we put a plate on the femur initially, and then also put an external fixator on the pelvis to get some kind of provisional reduction and stabilization. And once she was stable, we went ahead and did the major pelvic fixation and acetabular fracture fixation. She also had massive Morel Lavelli lesions which had to be dealt with multiple debridements and grafting. So there are some other important things that we need to look at in these patients, and one of this is hypothermia, which is often forgotten because hypothermia reduces oxygen delivery to the tissues. Okay, it also shifts the oxygen dissociation curve to the left, if any of you remember your physiology, but it increases the oxygen requirement because of shivering. Okay, so again, increased oxygen debt, further injury, again adding to the vicious cycle. There are also the other problems of silver day, poor debridement, compartment syndrome, crush syndromes, and these can't wait. You need to deal with them before it's too late. Otherwise, you'll go into this vicious cycle of hypothermia, problems with blood coagulation, and that is very difficult to get out of. So here's a patient, femur fracture, tibial fracture, also had an elbow fracture, a lot of swelling in the leg. He had an angio just to rule out a vascular injury, but you can see the open femur fracture, the tibial fracture, his toe was almost separated. It had to be separated, debrided, and he needed a sort of decompression. You can see that the muscle is already dying here. All that had to be debrided. But because that was done early, he was put on external fixators. We were able to salvage the limb and the patient, and later on go on to do the definitive fixations, which was a nailing in the femur. He had an elbow fracture, which had a tension band wiring, and the distal tibia open fracture. He had his grafts to cover the bare areas, and then had a Ilizarov ring fixator on that and went on to do well. Pain relief is another thing that is often neglected. Again, pain alters the physiological response, leads to a hypersympathetic activity, and can cascade the systemic inflammatory response syndrome, leading to worse results. So every patient needs optimization of hemodynamics, correction of coagulopathy, and rewarming, and then regular monitoring in the ICU to make sure that he's okay. There's another thing that has come about more recently is about fixing of rib fractures. Many of these patients who have a very severe chest injury have flail chests, which makes their ventilation difficult, and certain situations. This was a patient who was actually run over by a tractor and left for death, and then he came into our ICU. He actually was related to one of the ICU doctors, and he asked me, well, can you do something about the rib fractures? And these were segmental fractures on the left side going right down from the 2nd to the 9th ribs. So we went ahead, we fixed his rib fractures. So we put double plating on the 3rd, 5th and 7th ribs, which kind of stabilized his chest. He also had a fracture dislocation of the sort of mandibulosternal joint on one side. So we fixed that with a hook plate, which we designed ourselves, cutting a 1/3 tubular plate across there. You can see there is the fixation for the mandibulosternal joint, and he had a left clavicle fracture, which we also plated. And he went on, he was off his ventilator the next day. So this is one new aspect which is not there for every patient, but there are certain indications where fixing the rib fractures would help you improve the ventilation for the patient and reduce the ICU time significantly. So damage control orthopedics is not doing nothing. It's not an excuse to stay in bed or a convenience for the surgeon, but the idea is to first not to do any further harm to the patient and then repair. So you have a spectrum of care. extending from early total care or ETC to damage control, and this involves assessing the patient very carefully. There's also the concept of damage control resuscitation, which is a little different. We talked about it. Don't try to get the blood pressures back to absolutely normal. You need to make sure you control bleeding and keep the lethal triad at bay. So the timing of surgery would depend on the response. So you have this initial period where if the patient is stable and resuscitated, you can resort to early total care. In the more severely injured patients, you need to do damage control. You have this phase of hyperinflation between the second and fifth day, where you do only second look debridements, etc. And you have this window of opportunity between the fifth or sixth day to the 10th day, which is the best time to go ahead and do your definitive surgery. And again, a period of immunosuppression where you want to avoid major surgery. Again, the anesthetic resuscitations would be different before damage control and after damage control. So again, in the early phases, don't try to get the BP up to above 90. Once the damage control is over, you're sure the bleeding has stopped, then you can get the BP back to normal. Again, watch out for platelet counts, INR, etc. There are certain disadvantages of damage control orthopedics. So in patients who would have had early total care and have not had a major complication, they would get better much sooner. These ones would need more hospital stay, possibly more ICU days, increased costs, and pin track problems can delay your definitive surgery. And the cost of the external fixator is something which people have looked at recently, and it's really quite staggering to think of what these costs, especially because of the use of self-drilling shank screws and these fancy clamps that are used in the West. So you really need to look at the cost of the components of damage control as well. And so people have been looking both at economics and the medical side of this. And now from the Iowa group, they've sort of coined the term of early appropriate care. And Valia et al. Have sort of proposed that you don't have to wait for the lactates to come down to 2 or 2.5 millimoles. In the patients that respond, even 4 millimoles is okay. Go ahead and do your sort of definitive surgery and only employ damage control orthopedics for those with persistent acidosis. And they have been reporting better results with this. So, but I think to do any of this, you really need to have good facilities, you need to have a good team care, and everyone in the team has to be involved. Because here's an example, this patient who came to us a few weeks ago, that was his situation. His hemoglobin was 2. Like I said, mentioned earlier, his lactates was 6. He actually arrested in the first few hours after he came in. But by the time you got him to OT for his debridement, etc., in our setup, it gets late. He was put on an external fixator that helped him greatly. His next day was much better. His lactates were down to 2.7, but then the day after that, his hemoglobin dropped. His requirement for sort of pressors increased, vasopressors increased, and they found that he had an abdominal bleed. But the surgeons waited for 2 days before they went and dealt with that. By that time, his condition got worse. This was the condition of his leg. After that, he had done his laparotomy. All his muscles in this area were necrotic. We debrided that. But then his chest by then had got involved. He had sepsis. His urinary tract was infected. And then eventually he succumbed to all this by the 12th day. So you really need to have a good setup to deal with these very sort of severe trauma patients. And in the Indian scenario, the golden hour is really something which is still out of our control, but it's the silver day that hopefully we can make a difference to with our management. And the silver day priorities means getting the patient to the right hospital, getting him adequately resuscitated. We want to prevent hypothermia, do damage control, pain relief to try and improve the lot of these patients. So in summary, damage control orthopedics is really a form of temporary early total care. You need to carefully assess patients before you decide which line to take in these patients, and patients who are adequately resuscitated and stable will still qualify for early total care. But in patients who are either in extremis, that means their condition are just not responding, or in the borderline state, you have to make a careful decision as to what would be the appropriate management for them. And I think in our situation, probably damage control would be the best way to go for these borderline or extremist patients, because this reduces the risk of the second hit phenomena at a stage where the patient's inflammatory response syndrome is primed, and you want to avoid any major complications at that stage. Thank you very much. Hope you enjoy it.